Hello, my name is Alicia McDonald. I'm an assistant professor in the Department of Population Health at Hofstra Shore-LIJ School of Medicine, as well as Adjunct Assistant Professor in the School of Health Sciences and Human Services. Today's webinar is on oncogenic human papillomavirus, HPV, genotypes among women in South Africa. So human papillomavirus associated cervical cancer and HIV is relatively high in sub-Saharan Africa, with 23.5 million adults and children living with HIV. And the incidence and mortality from cervical cancer is the highest in the world. There are 2 vaccines available that target 2 oncogenic out of 13 oncogenic types, also known as high-risk types. Today's presentation discusses a study we conducted in South Africa that examines high-risk HPV types in HIV-negative and positive women. This study will allow us to see whether the current HPV vaccines are sufficient in reducing cervical disease and cancer in this population. But first, let's describe HPV. Well, it is a DNA virus. It likes to target squamous epithelial cell. It is the most common sexually transmitted infection worldwide, and most women are infected with at least one HPV type during their sexual lives. There are more than 150 different types of HPV, and approximately 40 of them are transmitted through sexual contact. There are 2 categories. You have your low-risk HPV types and your high HPV types. With your low risk, it usually can cause genital, and your high risk can cause cancer. And it can affect cancers such as causing cancers to the cervix, the vagina, the vulva, the penis, and anus. According to the International Agency for Research on Cancer, known as IARC, there are 13 high-risk. It is the persistence of these high-risk types that are associated with pre-cervical lesions or pre-cervical disease and cervical cancer. Of these 13 high-risk types, HPV 16 and 18 are known to cause 70% of cervical cancer worldwide. So what is cervical cancer? So it is when you have your normal cells become abnormal due to uncontrollable, resulting in a tumor. And there are 2 types of cervical cancer, and the most common is squamous cell carcinoma. So it's to develop cervical cancer, you need to have the persistence of the high HPV types. Now, the development of cervical cancer involves several transformations from normal to invasive cervical cancer. HPV must infect the basal cell, which is the only cell in the squamous epithelium capable of undergoing cellular division to establish a persistent lesion. So there are stages of cervical disease and to cancer. The first stage you have is when we look under histology, called cervical intraepithelial neoplasia, which is CIN1. And that is where you have mild dysplasia. And then you move on to CIN2 with moderate dysplasia, CIN3 with severe dysplasia, and then finally you're in cervical cancer. So this is based on histology, which usually biopsy is performed. But also there's other classifications of cervical disease based on cytology, which is from Pap smear, which you have low-grade intraepithelial lesion, and you have high-grade intraepithelial lesion. But for this study, we will focus on histology. Here is another diagram showing you the changes normal to invasive cervical cancer. As you can see, under exposure, you have HPV being introduced to your normal cervix, and then it can move on. Some people can move on to CIN1, and then from that group, some people can move on to CIN2, and then a few can move on to CIN3, and then from CIN3, some can move on to invasive cervical cancer. But with these stages, a person can regress. Their HPV infection, they can have clearance of this infection, and they can move back a normal cervix. So with your CIN1, you can have clearance of HPV and go back to a normal cervix. And even with CIN3, people can regress and go to C. And this progression can be caused, some studies suggest smoking, oral contraceptives, pregnancy, parity, nutrition, micronutrients, and other STDs promote this progression. Here's a graph from Ireland that shows the incidence and mortality rates of cervical cancer. And cervical cancer is the fourth most common cancer in women worldwide. As you can see from this, African countries have the highest incidence and mortality rates compared to other geographical regions. You can also see that South Africa has the third highest incidence of cervical cancer. And then North America is listed way down below. There are several meta-analyses that have looked at the prevalence of HPV types worldwide by cervical disease status. Now, in this meta-analysis, which examined HPV types among women with a normal cytology, we find that HPV 16 and 18 are the most common types worldwide. But when we look at the different regions separately, we get a different profile, especially when you look at the second and the third most common ones. South Africa, or Africa in general, bears the burden of cervical cancer. So it's important to know the most common high-risk types. In this meta-analysis, what we have in parentheses is the percentage of the study population that contribute to this meta-analysis. We can see that with the African countries, 2.7% of the population contribute to this meta-analysis. So the question is, the ones that are identified, are they the most common high-risk types in this region? Now here is another meta-analysis that look at HPV types among women with advanced cervical disease and cervical. Now again, HPV 16 is the most common type in women with high-grade squamous intraepithelial and invasive cervical cancer. But if we look among women with the advanced cervical cancer, we see that the proportion of HPV 16 among women in Africa is lower than what is observed in women from Europe and North America. And then also in this meta-analysis, the sample size from Africa is smaller than the other regions. As I mentioned earlier, there are two current HPV vaccines. One is Gardasil, which targets high-risk 16 and 8 and low-risk types 6 and 11, and is licensed for female and males aged 9 to 26 years. The second one is CERVICAL, which only targets high-risk types HPV 16 and is licensed to female ages 9 to 26 years. And CDC recommends that all girls and boys who are 11 or 12 years 3 doses of the vaccine over 6 months to protect cervical disease and cancer. So as I stated before with the meta-analysis, that problems are that with sub-Saharan African populations, they only contribute a small amount of data to these meta-analyses. There are limited numbers of studies that examine HPV infections population. Also, there are different HPV DNA testing methods that have been used. So some of them don't even test for all of the 13 high-risk types. Another issue is that in some of these studies, HIV positive and negative persons are not separate. So studies have shown that HIV positive women have higher prevalence of high-risk infection than HIV negative women. And also studies have found that HIV positive individuals have a different distribution of high-risk types than HIV negative women. And then lastly, specific high-risk HPV types are not examined by age and cervical disease status in most studies. So to address this issue, we wrote our first paper that looked at the distribution of high-risk HPV among HIV-negative women to see whether the current vaccine will be effective among South African women based on this distribution. And from this study, we found that HPV 16 and 35 were the most common high-risk types. Now remember, the vaccine covers high-risk types 16 and 18. For this paper that we're going to talk about today, we want to see whether HIV-positive women have a similar distribution of these high-risk types as HIV-negative women in South Africa. And by providing this information, we can recommend what the next generation of HPV vaccines should target to help reduce cervical disease in a geographical region that carries the highest burden of disease. So the purpose of the study is to describe and compare the prevalence and distribution of high-risk HPV types by age and cervical disease between HIV positive and negative. Also, we want to compare the frequency of multiple high-risk HPV types by age and cervical disease between HIV positive and negative. So we hope, like from this study, that we have a better understanding of the prevalence of these high-risk, and that from this information, this will allow policymakers to identify the best strategy to use to reduce cervical and cervical cancer in this region. So this study consists of a study population of women who participated in 3 subsequential cervical cancer screenings from 1998 to 2006 outside of Cape Town, South Africa. In cohort 1, women were recruited who were ages 35 to 65 years who participated in a study to evaluate the performance of different tests for cervical cancer screening. In cohort 2 were women ages 35 to 65 years who participated in a randomized clinical trial examining the safety and the efficacy of 2 screening approaches for cervical cancer prevention, and they were followed over 36 years. For this particular cohort, we only included people who had HPV genotype data. And then cohort 3 were women ages 17 to 34 years who participated in a study to examine HPV prevalence among younger women. Our inclusion criteria were the following: not pregnant at the time of enrollment, never been screened or treated for cervical cancer, have not undergone a hysterectomy, do not have invasive cervical cancer, had a known cervical disease status such as within normal, CIN1, CIN2, and CIN3, and signed an informed consent. So here's our diagram of our 3 cohorts. We excluded individuals who had cervical cancer. Most of these cervical cancer cases came from cohort. We also excluded people who had an unknown disease status. These were individuals who were lost to, and we had a final cohort of 90 women who were included in our final analysis. And I must state that this is the largest to date of women in which HPV high-risk types are examined across age and cervical disease status and substance. From these women, they were administered a risk factor questionnaire baseline. Their blood was collected for HIV testing. They also had their specimens collected, and from the cervical specimens, it was tested for high-risk HPV DNA by a hybrid capture-2 DNA assay. If they were positive for this DNA assay, we conducted a PCR to identify which HPV types that were found. And also, biopsy specimens were collected, and then that was used to determine the CIN classification. So, of the 9,400 women, the overall HIV prevalence was 14.6%. As you can see from the graph that the prevalence of HIV increased from 0.1% in women 17 to 19 years of age, and it peaked at 26.9% in women ages 25 to 29. And then it declines thereafter to 4.4% in women ages 55 to 60. So this table here, the study characteristics, describes the overall study characteristics of the study population by HIV status. And what we found was that HIV-positive women were younger, less educated, less likely to be employed, and less likely to be married than HIV-negative women. Also, HIV-positive women had an earlier age of first sexual intercourse and were more likely to be treated for sexually transmitted disease, but more likely to be using condoms than HIV-negative women. When we look at disease status, there were more HIV-negative women who had a normal histology compared to HIV-positive women. But there were more HIV-positive women with cervical disease compared to HIV-negative women. If we look at advanced cervical disease by age, and when I say advanced cervical disease, I combine CIN2 and CIN. We see that HIV-positive women have the higher prevalence compared to HIV-negative women, and is at its highest among women 30 to 34 years. For HIV-negative women, it also appears to peak at 30 to 34 years. Now, when we look at the overall HPV DNA prevalence or HPV DNA seropositivity, it was 25.4. When we look by HIV status, we see that HIV women have significantly higher HPV prevalence than HIV negative. So 52.4% versus 20.7%. When we look at HPV prevalence by age, we see that HIV-positive women have a significantly higher prevalence in each age category compared to HIV-negative women. Now, for both groups, the younger women had the highest prevalence. And a possible explanation for this is that the younger women could be more sexually active and therefore more exposed to more HPV types. And then what we see is that it does decrease over time for both HIV-positive and HPV. And this could reflect the clearance of the HPV infection over time. When we look at the cervical disease among women who tested HPV DNA positive, we also see that HIV-positive women have significantly more CIN1 and CIN2 compared to HIV-negative women. But there was no significant difference with CIN3. Now, this table describes the distribution of high-risk types, HPV types, among women with at least one high-risk type. So the denominator, or the number of women who have at least one high-risk HPV. This table is divided by cervical disease, and also the beginning of the table, we have the denominators of women in each category, such as the number of women who are hybrid-capture-2 positive, which means they're HPV DNA positive, as well as the number of women with a high-risk types. And at the bottom of the list are the 13 high-risk HPV and the distribution by cervical disease status. Now, when we compare the distribution between HIV-positive women and HIV-negative women, we find that among women who had a normal cytology or histology, that HIV-positive women were who had an HPV 18 was significantly higher among HIV-positive versus HIV-negative. Among women who were CIN1, HIV-positive women had significantly more HPV 39 and 50. Among women with CIN2, HIV-positive women had significantly more HPV 60. And then among women with CIN3, which is the next step before you hit into invasive cervical cancer, HIV-positive women had significantly more HPV 39 and now, when we look at these different disease categories, HPV 35 was among the top 2 of the most common types for HIV-positive negative women, and HPV 16 or 18 came in the second place. But we're going to focus on CIN3, which is the step before you hit cervical cancer. And within this HIV-positive women, the most common ones were HPV 16, 33, and 35. And for HIV-negative women, it was 16, 30, and 45. Now, when we look at whether a person has HPV 16 and or 18, we see, and we look by disease group, we see that that there's a significant proportion of them have 16 and or 18. And we see that when we look at the more advanced cervical disease status, that we see the height. So in CIN3, we see that HIV-positive women there's 66.7% who had a high-risk type, either 16 and or 18. And then HIV-negative, there's 48.6% of them having it. So these next set of figures are going to be the distribution of high infections among women with a high risk. And what I mean by infections is that a woman can have more than one HPV type. So a woman can have up to, we found in the study, can have up to 7 different HPV types that were detected. So the denominator would be the number of infections that were found. And in this graph figure, we have collapsed the normal histology with the CIN1 women, sorry. In these next slides also, we are going to be comparing between HIV positive and negative women and what are the most common types of infection. So with this graph, we found that there were no significant differences with the high-risk HPV infections between HIV positive and negative women. And there were no differences women having either HPV 16 or 18. This one is CIN women who are ages 30 to 39 years old. And here we found that HPV 68 was significantly higher among HIV positive women versus HIV negative. And again, we do not find any differences with women who have an HPV 16 or 18 between HIV positive and negative women. When we look at women who are ages 40 to 65 years who have normal histology in CIN1, we find that HIV positive women have significantly more HPV 18, but significantly less HPV 58 compared to HIV negative. And then again, we don't find that much difference with HPV 16 or 18 between these women. Now, when we look at women with advanced cervical disease among women who are 17 to 29 years, we find that HIV-positive women have significantly less HPV 18 and more of HPV 56 compared to HIV-negative. And what we find here is that there are more HPV 16 or 18 among the HIV-negative women. When we look at advanced cervical disease among women who are 30 to 39 years, we find no difference in the high-risk HPV. But we do see that, again, HIV-negative women have HPV 16 or 18. And when we look at women who have advanced cervical disease who are ages 40 to 65 years, again, we don't see any difference in the high-risk HPV infection. But we do find that HIV-positive women have more of the HPV 16 or 18, but it probably is not significantly different. Now, this table here shows the frequency of the multiple high-risk HPV types by age and cervical disease in HIV-positive and negative women. And what we can see among the HIV-positive women, that 40.9% of them had at least 2 or more high-risk HPV types, compared to the HIV-negative who have in 24.3%. Now, among the HIV-positive women, there were up to 7 different HPV types that were detected. Some for the HIV, even the HIV-negative women, there were some as high as different high-risk HPV types that were detected. When we look by cervical disease, we find, and by age, we find that the HIV-positive women had more multiple high-risk types compared to HIV-negative. When we look among women who had normal histology and CIN1, we see that this higher number is significantly, that HIV-positive women have significantly more of these multiple high-risk types compared to HIV-negative. But when we look at advanced cervical disease, we only find that among women who ages 30 to 39 years. So in summary, HIV-positive women had an overall higher high-risk HPV prevalence. There were more cervical disease. They had more multiple high-risk HPV infections compared to HIV-negative. Regardless of HIV status, HPV 16 and 35, 16, 35, and 58 were the most common. When we look at women with CIN3, pretty much one step from invasive cervical, the most common high-risk types were among HIV-positive women were 16, 33, 35, and in HIV-negative women, 16, 35, and 45. Now remember, the vaccine covers 16 and 18. But we do find that 16 and 18 do contribute a significant portion in this population and contribute most to these high-risk HPV infections. So even though our study was the largest study in sub-Saharan Africa that examined high-risk HPV types by age and cervical disease, there were limitations. One was that we lacked clinical information on HIV status, such as viral load, and the use of antiretroviral therapy. So we couldn't look at it with its relationship with cervical disease and high-risk HPV. Also, there were some individuals who were hypercaptured DNA positive or HPV DNA positive, but we weren't able to detect those high-risk types, the specific high-risk types, through PCR. And then finally, we did not have enough cervical cancer cases to look at the high-risk types among these individuals. So in conclusion, again, to our knowledge, this is the largest study to date that compare high-risk HPV types between HIV-positive and negative women with known cervical disease in sub-Saharan Africa. We've shown that HPV 16 and 18 are is significantly a good portion of among women who have a high-risk type. So therefore, the current vaccine will be effective against the cervical disease, among the South African women. However, we did identify other types that are not covered by the vaccine, such as HPV 35, 30, 45, 58, that were not covered by the vaccine. So having a second generation vaccine that includes these types will to reduce HPV infection even more in populations at high risk for advanced cervical in sub-Saharan Africa. So this is the end of the webinar talk. So we have one question here. And one is, what could explain the higher high-risk HPV prevalence in HIV-positive women compared to HIV-negative women? Well, one thing is that it could be with HIV-positive women, it could be like behavior differences, like sexual behavior differences. And with that could be, risky behavior, sexual behaviors that will allow them to be exposed to more high-risk HPV types. Also, having HIV, you may be more susceptible to having HPV infection. Another one, being HIV positive, it can be, there's immunocompromised status, and so there could be a possibility of them having a greater persistence. Therefore, they're not able to clear the HPV infection as a HIV negative person will be able to do, as well as they also may have more reactivity. So unfortunately, with our study, we weren't able to examine these things, but these are possible explanations for that question. Okay. Another question we just received is, do the current vaccines provide some type of protection against other high-risk types? Which is a really good question. So yes, there is some cross-protection for some types that are found to be similar to the vaccine types of 16 and 18. For example, some studies suggest that there is some cross-protection for HPV 31, 33, and 45. But this is cross-protection, so it's not going to be as effective as if the vaccine target these. Now, as you can remember from the presentation, that HPV 35 was at least in the top 1 or 2 across cervical disease, and these vaccines do not provide any cross-protection for HPV 35. So therefore, we're missing out on those people who are HPV 35 positive. Okay, another question is there a second generation of HPV vaccine being developed to target other HPV types? So yes, there is. There was announced that a second generation vaccine is out. That was announced in 2013. It is a 9-valent vaccine, so it targets an additional 5 oncogenic HPV types. So it targets not only just 16 and 18, but also 31, 33, 45, 52, and 58. So as you can remember from the presentation, that 16, 35, 33, 58 were some of the common ones. But again, this new vaccine that actually is under phase trials right now, it still doesn't cover 35. So we're still missing 35. So we're still going to miss some people who are affected by this virus who have 35. Okay, and here is our last question I'm going to take. Were low HPV types found among these women? So yes, among all women who had a high-risk HPV, at least one low-risk HPV type was found. So remember, with our methodology, we only did a PCR to identify HPV types on individuals who actually tested positive for the hybrid-capture 2 DNA assay, which screens whether they are DNA positive, the 13 high-risk types. So only among women who actually had a high-risk types, we were able to look to see whether they had a low risk. And all of them did have a low-risk type. And if you can remember that one of the vaccines covered HPV 6 and 11, those low-risk types that causes genital warts. And within our study population, we did find HPV 6, but it was detected less than 1% among HIV-negative women and less than 4% among HIV-positive women. But we didn't find, didn't detect HPV in our study population. So this will be all of the questions. If you have any additional questions, you can email me at amcdonald2@nshs.edu, amcdonald2@nshs.edu. And thank you very much.